Okay, first I want to give you a little bit about my table of contents of what I'd like to cover in the next half an hour. And I'm going to go pretty fast because doing freestanding EDs in half an hour is kind of a challenge. So there's going to be some parts that are compressed, and I'm not going to go all over all the slides. And I've rearranged the slides a little bit from there, but you won't get lost in it. Anyway, we're going to talk about the difference between a freestanding ED and a HOPD. An HOPD is something that a hospital owns. I'm going to cover our story of how we got our freestanding running from House Bill 1357, which we had to introduce in the Texas legislature, all the way up to Chapter 131, which are the rules and regulations that govern freestanding emergency centers in the state of Texas. I'm going to cover about why I don't think freestanding ERs are going away. I don't think they are. I'm going to cover why hospitals have a hate-love relationship. It isn't love-hate. They hate you first, then they love you. I'm going to cover a little bit about how it can solidify your hospital contracts or hurt them if you don't do it right. And then I got a little bit on the mechanics of building one and the reimbursement about getting paid while you're in one. First, HOPD versus freestanding ED. Digress a little bit. This was a Parade magazine from 2004, and this is when I first thought that freestanding EDs, right around this article. I've been carrying this thing around since then. Anyway, it's an article by Sean Flynn in Parade magazine, which I found out later was the most published magazine in the world, mostly because it's free in every newspaper in the world. Anyway, it says How to Stay Safe in the ER by Sean Flynn. It's actually not a bad article. Tells you if you're not too sick, call your doctor, that kind of normal stuff. But what caught my idea was the waiting room, which I zoomed in on. This is a waiting room where you need to be safe in, right? So this waiting room has people dying, or at least that's what you're led to believe. But I looked around this waiting room here, and I couldn't actually find any sick people in here. I see there's 3 people reading the newspaper. There's 1 person reading a book, if you look at the original. There's 3 people watching 3 people read. There's this person in a wheelchair, and honestly, I'm not sure what they're doing. Presumably they've got a twisted ankle or something. I think this one lady on the left is knitting, but I can't really tell in the actual picture. Anyway, so being sick in the ED is a matter of perspective. So House Bill 1357, before I go on, I need to put in a little word about these HCAP statements. In our division, we see about 500,000 people in our group, and we get HCAP's results, we get our results, and we also get the comments. And so these are comments that came through HCAP's reporting directed at our group and our hospitals. So some of them are kind of interesting. Bless this woman's heart. We know exactly what she means. An HOPD is a off-campus emergency department of a licensed hospital. This terminology really is growing out of Texas. Generally across the country, we still say FSED, referring to different kinds of facilities. In Texas, an FSED is a facility that's not affiliated with a hospital. An HOPD is a hospital licensed facility, and in the state of Texas, it's not really regulated. We staff 5 such facilities. When the Joint Commission comes, they never go to the HOPD, which is licensed by the hospital. They don't set foot in it. They don't even know where it is. There's no architectural requirements for it. They do have to obey the rules of their license, which means they have to take Medicare and Medicaid. The goal of the thing is multifactorial. They want to expand their geographic region. They build them where there's rich people. They want funded admissions. That's kind of the bottom line about a HOPD. A large national hospital company, this is data they gave us from last year, has 22 HOPDs across the southern United States. 16 of them at that moment were being built. They have 30 more planned for this year to bring our total up to around 70. So to think that HOPD model is going away would be a little naive. This large hospital company is building a bunch of them. When you add it up, that's way over $1 billion worth of stuff that they're pumping money into. An FSED is an independent, non-hospital associated emergency department in the state of Texas. It's licensed that way. It's licensed under Title 25, Chapter 131 of the Texas Administrative Code. It doesn't have EMTALA obligations if you do not take Medicare or Medicaid, and none of them do, because there's a significant disadvantage that comes with that. The law has EMTALA-like language, so you do have a medical screening obligation, but the infrastructure behind that part is completely different than the infrastructure behind an EMTALA violation. So it's a little bit more rational, actually. Most of the FSEDs in Texas, of which there's around 100, are owned by physicians, but some are not. One is owned by a venture capital company, the largest one. They have 15 FSCDs. They built their first one out of state recently. I believe we're second. And then there's one that's one company run by a nurse. I just don't think they should have all those people with viruses sitting next to all of us. They were throwing up and had little green bags, which made me feel kind of good because I don't think any of our hospitals have little green bags. So this family was nice enough to bring their own little green bags. Bless their hearts. That's what I got to say. So here's our story. In 2006, we thought we ought to be in the freestanding ER business because it could diversify our revenue stream. It was the independent practice of emergency medicine, which I liked a lot. I don't like being the bitch of the hospital administrator, and I'm sorry for dropping the B-bomb. I'm thinking that we have to go in bomb order, so alphabetic, but I'm glad I'm not the next guy. We're a very entrepreneurial group, and we do a lot of entrepreneurial things, and so this fit in with our vision of being entrepreneurial. This is one of our waiting rooms, our first waiting room, actually. We found a little piece of real estate. We put together some financing. At that time, there was no law. We had introduced the legislation with our guy, and we had a little coalition. Then we marched off to Austin every week and pursued our vision of having a law that regulated these things, because that solved some billing issues and a few other things. So we found a little hospital partner, a little 5-bed ER owned by a little 5-bed hospital owned by an ER intensivist. We partnered with him. Basically, we rented his hospital license so we could operate as an HOPD of his hospital, which has a whole mess of problems associated with it. Our bill passed both houses of the state legislature and then died at the end of the session. Texans believe that when the legislature is in session, the citizenry is at risk. So as a result of that, that's a fact. The Texas legislature meets for 180 days, and at midnight on the 180th day, the gavel falls, and the guy watches the clock, and that's it. Whatever was done prior to that moment becomes law, or at least goes to the governor, and whatever was pending after that is deceased. The legislature can only meet on odd-numbered years. So this law, when we had this, which passed unanimously but died procedurally as the time ran out, pushed us two years beyond, because there's no way to get that done for 2 more years. Anyway, so we stayed down on our HOPD track. We finally got our building built. This is what it looks like, the first one. We decided to call it Elite Care, which I thought was a little bit hokey. You know, it just sounds kind of goofy. But as time goes by, we developed a following around it, and we decided we could be elite. And so the way we do business revolves around elite. When we chastise a doctor or nurse for not being nice, because we expect brilliant medical care, we say that you ain't being elite, and if you ain't elite, you can't work here. People want to work here. We see from 10 to 30 patients in 24 hours, 30 being a big, giant, busy day. In our hospital-based ER 4 miles away, we see 190 patients a day. So there's a big difference between working here and working in a hospital-based ER. Acuity is lower, too. Another picture of it from the outside. We opened for business of this HOPD of this small hospital. Our reimbursement issues are resolved. Insurers want to pay us because we're a licensed hospital, so that problem didn't exist. Some of our other groups around the city didn't do this, and they were fighting with Aetna and Humana to get paid, and Aetna and Humana saying, you ain't even licensed, we're not paying you nothing. So the suits were flying back and forth. We slept under the radar by renting our hospital license, which was perfectly legal at the time. But the hospital partner had issues, that being stealing our money. So we've regrouped our effort. By now, 2009 rolls around, legislature back in session. We got more support. We got more guys to support our bill. We get it passed early in the session, passed unanimously, both houses. Governor signs it, becomes law. Got 18 months to write the regulations, then the rule will start around 2011. So we're all happy, but we still have to operate as an HOPD. Here's the law. It's 13 pages long. Here's the rules and regulations that came out 18 months later. And I put up the last page here mostly to show you that it says this is page 160. So there's 160 pages of regulations on a freestanding ER. The last half is architectural. When you look at the hospital regulations, which is section 133, they're 240 pages long. So we're 3/4 of the regulatory obligations of a hospital. So it's quite a deal to build one. The second HOPD partner we had began to steal our money too, and they also were going broke. So we decided that the whole HOPD model as physician owners was really not going to work for us. The Texas Department of State Health Services thought it was too, because this HOPD partner had 90 ER beds affiliated with it on its rent-a-license program. So there was 90 freestanding ER beds around the city of Houston that were all licensed through this 20-bed hospital, and the state thought that was a little hokey. We did too. Didn't pass the smell test, so it's the day we could, we converted to an FSED. We were the second one. We would have been first, except we had some contractual issues with the first guy that are ongoing. Here's what the license looks like. So now we have a license. It looks exactly like a hospital license, except it says freestanding emergency medical care facility, which is the official state name in Texas for them. Houston has 54 freestanding ER buildings, 38 of which are FSEDs. The rest are HOPDs. Every hospital system, of which there's 3 in Houston, has HOPDs. We staff our hospital systems. We have 5 of those. We have 2 freestanding EDs in that city, and we go to other cities now. So there's about 1 FSED for every hospital, which brings up some HR issues. One, you got to almost double the number of ER doctors for that city. Each FSED needs 5 FTEs or 4.5 of physicians. So that's 50 times 4 is 200. There's probably 300 ER doctors in the city of Houston a few years ago, last time I counted. So it's a big hit on the HR. You can pay pretty good here because they make good money, so you can be very competitive in terms of pay with a hospital, and it's a nicer place to work. That's one of the reasons why they're not going away. I'm going to go through a few slides on why I think the FSEDs are just not ever going away. This is a study that was done by the American Association of Medical Colleges, which shows there'll be about 100,000 doctors short by 2020. It says 91.5. I think it's a little closer to 100,000, 50,000 of which will be primary care. At the same time, we're going to see a decreasing reimbursement rates that I believe will approach Medicare. I don't think any reimbursement guy in here doesn't think that every single insurer is trying to drive our reimbursement down to Medicare, and now they all want to negotiate as a percent of Medicare. And I know people who take less than 100%. So getting our reimbursement close, we're going to take a 2% pay cut on Thursday because that's part of sequestration. So our rates are going down. Everybody has seen this slide, number of hospital beds and our beddedness of ER beds, ICU beds, and telemetry beds, and probably a general inpatient bed are all shrinking, have been. We also know that more patients, we've seen a growth in the number of patients that come to the ER in the late 80s of 90 million to now we're up to nearly 140, 150 million patients per year into EDs. A lot of them have dental problems. A past board member of HCAP gave a lecture one time and he referred to our specialty as TB and A. You know, like E and T, where you name it sort of after a body part. We were TB and A, tooth, back, and ankle. Tooth, back, and ankle specialists. So there's going to be a PCP shortage. That's a given. There's a bed constriction problem. That's a given. This has all occurred before the Affordable Care Act is kicked in. This is front of our first freestanding building. This building's 18,000 square feet. Has a 2-bed inpatient unit in it, and we have 9 beds inside it. There it is from across Interstate Highway 45. So it's a formidable building. We do quite well there. Then when you walk in the door, that's what you see. So we like it sort of in a spa environment. Back to reality here for a second. So our core business, really, the delivery of emergency medical health care in hospital-based places, is going to, these things will happen. Our waiting times are going to go up. We're going to see 40 million new empowered insurance card holders through the exchanges and through Medicaid expansion. Our acuity is going down, has been going down for the last 10 years, and will definitely keep going down as our TBA designation expands. There's going to be a worsening patient care experience. The little ER we saw in Parade magazine from 2004 is going to look uglier. The commercially insured patients are certainly the ones that we see, which is the ones we target, are not going to tolerate that. They don't like people with little green bags sitting next to them vomiting. Nobody likes to sit next to somebody in the ER with snot running down their face. Stuff like that. Nobody likes that at all, and that's the environment that we're exacerbating in a hyper-acute way. 2014, 2015 is when this is going to happen. There's not going to be a massive expansion of inpatient beds or ED beds. In our hospitals, of which we have 9, average volume 60,000, there is zero plan to expand any ER in the next 2 years. And every one of them is at capacity. Zero plan. So these patients are going to find somewhere to go. This is basically the same thing. I just want to keep, I guess I wanted to beat it into my own head, but the freestanding ERs are here to stay. The commercially insured group of Americans, of which there's about 20% of us, are not gonna, once we go to a place like this to get our care, we're not gonna go anywhere else. Our biggest customers are repeat customer. In our ERs, we do 100% patient satisfaction surveys, and our biggest, I call it an accolade, but the biggest comment is, please never take Medicaid. So we don't take Medicare or Medicaid. That said, any sick person that walks in the door gets taken care of. We do that. We just build them where there's not so many. It's just like a hospital that's in a good neighborhood, zip code depending. When the Affordable, I wrote this as the Affordable Care Act was going through its Supreme Court thing, and still it's at risk for surviving. And some parts of it clearly will and clearly should. Some parts of it probably won't. But there's going to be around 40 million new empowered ED customers. ED is going to be more and more overcrowded. We're regressing to a Medicare or worse pay schedule. Our waiting rooms are going to get uglier. Patient experience is going to deteriorate. And this void is now being filled, and people are already voting with their feet by going to freestanding ERs. And they are popping up everywhere all over Texas. I mean, they are churning out a license. You can go on the website and see where they put out licenses, and they're coming out 1 a month, 12 a year. That's 10 times more than the hospitals are being built. This is going to drive hospitals to lose a little bit of control, try to employ physicians. They're already doing that. Our traditional emergency medicine business model, I think, is going to worsen until we're completely employed by the hospital or the government. There's a large healthcare system that I happen to know about who has the budget for 2012 for employed physicians was $1.6 billion, 11,200 employees. So it's a big deal. Can anybody tell me what that TV show is? That's in our waiting room in League City. SpongeBob, exactly. SpongeBob SquarePants. We normally show sports because there are more women inside our ERs than men, and their men come with them, and they have to be there because they're their men, and they like to watch sports. We had one woman had a kidney stone, and she got taken care of, and we took care of her, and we got her all better, and it's 2 hours in there, and she comes out ready to go home, and her husband is in the middle of a football game, and he don't want to go. Because we got everything but beer in there, and we got a nice TV, and he says, wait a minute. She gives him a look like, you've got to be kidding me. So the solution to this overcrowding problem is on this list. This is everything I could think of that would help to offset that for the commercially insured patient or the patient willing to pay for health care. Retail clinics, every one of these things we're seeing grow right now, big time. Every one of them. So we're just part of the freestanding ED movement. Here's an article about wealthy people they want a little exclusivity. They just want to go. Our target patient is the insured, not the wealthy. The wealthy are kind of a pain in the ass. but the insured are not so much so. Hospitals, and oh, here's one. I was given IV fluids and had to use the restroom by myself. You know, I was at the Daytona 500 last weekend, and I drank quite a bit of beer, and I had to use the bathroom by myself. And so I fired a letter off to Mr. Weiser. I said, Bud, dude, don't make me go to the bathroom by myself again. Hospitals love the HOPD concept, right? It expands their geographic area. They get funded admissions from that. They get referrals to their employed physicians. They make money. They hate freestanding ERs because they're competitors. It's written up there twice. They lose control of the patient. So if I see a back pain patient who's going to subsequently need an MRI in the ED setting of a hospital, I'm going to refer him up their chain of referral command. But in the freestanding ER, I get to do whatever I want to. I don't have no contract at risk there. So they lose that control. The ED doctors get leverage because you have admissions now. You become the CV surgeon to the CEO. Every CEO kisses the CEO surgeon's butt. I can't say ass because that was taken. So kisses their butt. They have to because they generate millions of dollars of revenue. Now we're in a position to generate millions of dollars of revenue. They like admissions, and they like admissions a lot, especially when they're funded. Average admission, we all know, is around 60%, 50% from the ED. We heard about that earlier this morning. Freestanding ERs that are owned by emergency physicians are the independent practice emergency medicine, which I really like. I like the responsibility of being in charge of the CAT scanner and the x-ray machine. I like the fact that the nurses work for me and not for a hospital. I like the fact that I'm in control of all of those features and that I'm willing to get control and make it happen and make it be an elite experience. Corollary to that is when you control the patient, you tend to control everything from a healthcare perspective. You become the good guy as opposed to being an ER doctor in the ER, you're the bad guy. CV surgeon, neurosurgeon, orthopedic surgeon, all good guys. ER doctors, bad. The subcorollary to that is because we control the patients, and you can scratch out the word FSED from here, one commercially insured patient admission per day, and by commercially insured, I mean regular insurance, not government, is a multi-million dollar, the actual number is $4.4 million positive EBITDA experience. That's bottom line profit to the hospital. So if you admit one patient today and you're a family practice guy, the hospital administrator kind of has to kiss your butt. And that's what we end up doing for the hospital. So they love that. And they end up relying on you to provide them that. You have a relationship problem with them too. You need a hospital admit patients. You need a place where you can emergently send, seconds to minutes emergencies like bleeds and heart attacks. You need that access, and they want your patients. And so it's a happy symbiotic relationship. You end up controlling the patient and his destination. You control your payer mix through aggressive screening. And I don't want anybody to think we don't take care of every sick person that walks in. Every door we staff, 23 contracts. If you're sick, we take care of you and we just eat it. But we're just aggressive about taking care of if you're sick or not, which most people don't, or we don't do a good job of in the hospital, but we do a much better job of in that environment. They also have a nice zip code to live in, so there's not a lot of where that's a big deal. Say that again? The volume is controlled really by turning the spigot on your advertising dollars, and you can really do that. Our advertising budget is about 30 grand per facility per month. So it's bigger than most of our hospitals' annual advertising budget. You can do all kinds of focus, and we do every single one. You can do better than zip code. You can do geographic circles. And we don't just target, we do every mode of advertising, radio, TV, print media, community support in terms of sponsoring community events, Little League. We do flyers, but they're usually not very valuable. We usually have a radio personality, continuously advertise us. And it really depends a little bit on the community billboards. We do all of that stuff. So I've already sort of covered about why the hospital if you're a hospital contract-based provider like we are, is happy to have you as a freestanding ER more than, they want you to be 6 miles away because that's about their catchment area. But you need a hospital. I've covered this. You need a hospital and they need you, and so there's a happy symbiotic relationship. And it turns out to be a pretty good relationship, much better than you can have by not being a big admitter. This is our one of our nursing stations. The nurse never went into the room. The only person who went in the room was the doctor. It was the doctor who did everything. So I like this patient. Bless her heart. See, I think the catch here was that this was a male nurse and a female doctor. Be my bet. Anyway, doctor gets full credit. A little bit on the mechanics of opening one. I'm going to go through this real fast. You got to go through the Department of Health before you start design, because you have to get it approved by the state before you can design it. It's built a lot like a hospital in terms of all the architectural requirements. The square foot requirement dollars is about 50 more per dollar than typical commercial construction. You got to have all kinds of architect. You really need a developer. The city and the city planners and the permitting processes, it can be hugely onerous depending on the place, or very friendly depending on whether they want you there or not. You got to be a CLIA approved registered laboratory and CLIA or COLA inspected. You got to go through the National Practitioner Data Bank. You must have transfer agreements with hospitals. Your memorandum of transfer is approved by the state. Once you open, you can apply for a pharmacy license. In Texas, you have to have a licensed pharmacy in the facility, just like the laboratory. Certificate of occupancy is delivered by the fire marshal, basically. The imaging component is moderately complicated because of the radiation that's in there, and you got to have physicists and stuff like that. Then you got to have contracts. We have about 35 contracts per place. Got to have supply, delivery, housekeeping if you don't keep it in-house. Pharmaceuticals are a big deal, especially with the whole shortage deal. You need multiple vendors for pharmaceuticals, so you don't want to run out of drugs. You got to create a medical body, just like a hospital. You got to have a board, a governing board is what it's called in Texas. It's the equivalent of the Board of Trustees. You got to have a MAC, which is a Medical Advisory Committee, which is the equivalent of the Medical Executive Committee, and under it, all of the quality committees that go with that. I mentioned the Class F pharmacy. You'll end up getting its own DEA number in the state of Texas. You got to get a Department of Public Safety license as well. You have to have a pharmacist. CLIA I mentioned. Human Resources gets a little dot in an HR, but it's a giant deal. You're hiring a lot of people, a lot of payroll, a lot of employment-related issues, and you got to have somebody that knows all of that stuff, benefits, things like that. You become a much bigger employer than you are just employing physicians. The Department of Health is involved in every step of construction. They inspect it frequently during construction. They approve it at the end of construction. They pre-approve your plans before you can even start construction. After 100 patients, they come and do an inspection. Happy to say we always pass those. Policies and Procedures is a book as big as the hospitals, P&P. It's a big, thick book. You got to have them. Then you got to have all these ongoing reviews. I'm trying to hurry to get to my last HCAP slide because it's my favorite. HR, see how important I thought that was? I put it twice. And then you start your advertising and your State Department of Health. The Joint Commission doesn't have a review process for freestanding ER, so you can't get that. They do have an ambulatory surgery center one that they adapt to it, so you can get the sticker on the window if you jump through the ASC hoops at some of them, and they sort of do it, but they're in the middle of figuring out the standards mechanism for freestanding ERs right now, so I think pretty soon we'll be able to do that. I have one slide on reimbursement because I'm not a reimbursement guy. I know more about CRAPs than reimbursement. Generally, there's no upside to taking government payers. It obligates you to all of the rules and regulations of being a Medicare participant, which is a thick, onerous book. It obligates you to be EMTALA compliant, which we are conceptually, but there's the downside isn't as bad if you make a mistake or if somebody accuses you of one that didn't even happen, which happens more often than not. So none of that stuff applies to us. You can bill Medicare for the physician fees for the 9928 codes, but but you can't charge the facility fee, which is where you actually make money. And the facility-based billing is a significant learning curve that's not generally known by ER billing companies. This is the second to the last one. I waited 2 to 3 hours and finally left because I was sick of waiting. My pain wasn't worth all that wait. Bless this guy's heart. Is this a frequent flyer, technically, if he leaves because his pain was beyond the wait? This is my favorite. The physicians need to cater more to patients instead of the nurses running around in their little short skirts. Now, this was in one of our ERs. I don't know which one, but I want to bless the heart of that woman running around in the little short skirt. I never have seen her. These are just some pictures of our ER. I'm done. I'm going to go through these pictures real quick. These are several different of our ERs. This is our newest one, opened about a month ago, 22,000 square feet. There's our waiting room. So we got nice leather couches there. That's a good question. I don't think so. Because we're not, no. Yes. Yes. We have to be participants in the EMS system. That doesn't mean you have to take them or not take them. We want to take the right ones, but we don't want to be a drunk dumping ground. So that's a delicate issue.
How do you handle the transfers of critical patients? Do you speak to the specialist if you have a head bleed and make arrangements for directly to the
Absolutely.
hospital?
We are an ER.
The second question is, do the same physicians work in the standalone ED as work in the
The answer to your second question is yes. The answer to your first question is we view ourselves as an ED extension of whatever hospital we're transferring to, and if they don't view us that way, then we find a new hospital. So if I have a STEMI patient, we'll know way faster than we will in the hospital because we get EKG immediately. It's generally only 1 of 2 patients that are there. We'll know within a minute or two. We call our transfer company. You cannot call 911. That's against the law in the state of Texas. But we have agreements with multiple hospital companies to be there just like that if we call them, and they have been now. So far, we've never failed at this. They go straight to the cath lab. We call and activate the cath lab, and then we subsequently call the cardiologist, or they do, or in the case of a STEMI. Or if we go to the ICU, we go directly there. Does that answer your question? I think I got to stop. But I'll be here tonight for the reception if anybody has any further questions. I appreciate your time. Thank you.